Hello and welcome to another episode of ICU Doc Talk. Thanks for joining me today. Today I'm going to be talking about heart block, what it is, the variations that it takes, and what to do about it. I'll be discussing that, and then I'll be talking about some books. I think I'll talk about two books today. One is called Nuclear War, A Scenario by Annie Jacobson. The other one is called Strongmen, Mussolini to the Present by Ruth Ben-Ghiat. There we have it. Let's get started. Okay, so what is heart block? So I made an episode a couple weeks ago about arrhythmias, and I talked about some common arrhythmias, AFib and VTAC and stuff like that. You can go back and listen to that. And during that episode, I was like, you know what? I need to make an episode about heart block. Now, heart block is, I guess it technically is an arrhythmia. It's a type of arrhythmia, I guess. But to me, I categorize it as it's kind of its own thing, what heart block is. So what heart block is, and I discussed a lot of the physiology in that episode, which is titled Heart Arrhythmias. So you're, just to back it up, the basic physiology, your heart has a nervous system in it, right? And it has a SA node. It has a sinus node where the like the pacemaker that happens in the right atrium, and that travels through nerve tissue through the down through the junction of the ventricles in the atrium, the AV junction, right? And then it goes down the bundle of His and the Purkinje fibers, and it goes down the apex and it comes back up. This is the metronome, the electrical metronome of the heart that dictates the pace of the heart, right? And the taskmaster is the sinoatrial node, the SA node. So when someone is normal sinus, we mean the atrium are contracting, and then that's followed by the ventricles contracting. And when you look at a QRS, the P waves are the atria contracting, and when you look at an EKG, man, I'm all fumbled around. When you look at an EKG, it's the P waves that show the conduction of the atria, and then the QRS is the conduction of the ventricles. That happens right after that. And the atria should always precede the QRS, okay? And the electrical conduction, when it's blocked, right, when there's a delay or an interruption of that transmission of that impulse from the atria to the ventricles, that's heart block. And as lots of things in medicine, there's a spectrum of how much this is blocked. So the block, when we refer to heart block, is literally the electrochemical blocking of that signal down to the ventricles. And it's usually due to an anatomical problem or an impairment of that conduction system. It can be inflamed. It can be damaged. You can have a worsening cardiomyopathy that's causing this. You can just have cardiac surgery that causes this. That's usually my arena. That's usually when I see it. That's why I can sniff it out really good in my patient population. Someone that has cardiac surgery, they're at very high risk to have heart block. And as I said, there's a spectrum of heart block that people can be in. Some of them are benign. Some of them are very dangerous. So let's just walk through the different heart blocks that there are. So the first heart block is first degree heart block, right? And the first thing you can think about this is it's a delay, but it's not an interruption in the conduction, right? So it still conducts through, meaning the pacemaker still fires. You still have a P wave, and it still leads to the QRS, and it's defined by a PR interval of greater than 200 milliseconds. Okay, or those are 5 small squares on an EKG strip or a rhythm strip. Okay, 5 small squares or 200 milliseconds. If it's that long or greater, you have first-degree heart block. It is benign. Okay, first-degree heart block is benign. Again, there's the delay, but the conduction still follows through. Now, some people can just have this. It can be caused by just increased vagal tone, increased parasympathetic tone that's causing this delay. Athletes can have this, but it can also be a sign of pathology, right? Myocarditis, electrolyte disturbances, and then also AV nodal blocking drugs, right? So any heart block could be iatrogenic, meaning it's caused by medications. AV nodal blocking agents, like beta blockers or calcium channel blockers, digoxin, amiodarone. Right? There's a whole slew of AV nodal blocking drugs that patients can be on that are routinely used that can push someone into heart block. And also, first degree heart block can just be a normal variant of normal physiology, of normal human physiology. Some people can just have a longer period interval. But the main thing to think of, it is benign. But hey, maybe there is something reversible, like an electrolyte disturbance, like hyperkalemia, or too much of a, maybe their AV nodal blocking agent that they're on needs to be redosed or reconsidered by whoever's prescribing it. But generally, the things you remember about it, greater than 200 milliseconds, it's benign. There's not much to do about it, and you're good to go. Just be like, oh yeah, patient's in first degree heart block. Okay, there's not much to do about it. Okay, now let's get into the second degree AV block. Okay, so there's second degree. There's type 1, Mobitz type 1, and there's type 2, Mobitz type 2. The Mobitz type 1 is also called the Winky-Back phenomenon. So it is also benign. This is characterized by the PR interval progressively increasing with then a drop in conduction. Okay, and then it regains it back. So the greatest way that this is characterized is that PR interval gets longer and longer and longer, and then you get a P wave, and then you get a block, and you don't get a QRS wave, and it drops off, and then it restarts itself again. That is second degree type 1, Mobitz 1, or the Winky-Back phenomenon. Okay, the PP intervals remain relatively constant throughout this. Okay, Mobitz 1, or second degree type 1, is usually due to reversible conduction block at the level of the AV node. And what are the causes of it, right? Same thing I just discussed. You can have beta blockers, calcium channel blockers, digoxin, amiodarone, increased vagal tone, myocarditis, anything. Those things that cause first degree that I talked about can also cause second degree type 1 or Winky-Back, okay? The clinical significance of it is it's also benign. Maybe it can cause minimal hemodynamic disturbances. There's a very low risk of progression. Patients are asymptomatic. If they're symptomatic, maybe they need to be treated. They need to, you need to raise their heart rate up or something like that. They rarely need any pacemaking. By the way, pacemakers are going to be a part of this discussion today when I get to the other disturbances, right? But again, second degree type 1, Winky-Back, Mobitz 1, is defined by a progressively lengthening PR interval that drops off and doesn't conduct, and then it restarts again. These patients are hemodynamically stable. They're asymptomatic, and this is benign. Okay, moving on. Now things get pathologic and you need to do something about it. Okay, so first degree and second degree type 1 or Winky-Back or Mobitz type 1 are benign. Everything after this in this spectrum of heart block are pathologic, and you got to do something about them. So heart block second degree type 2, Mobitz type 2, is pathologic. And there is the main how you distinguish this from second degree type 1, Mobitz 1, is that the PR interval is constant and then it suddenly drops off. You suddenly don't have a conduction after normal PR intervals. Okay, you don't have that increasing lengthening of PR interval. That's second degree type 1, and that's benign. This is where it just suddenly drops off. Okay, and you don't have the lengthening. It's usually Mobitz 2 is usually from a failure of the His-Purkinje system below the AV node, whereas in Mobitz 1, that's usually a suppression of the AV conduction due to like drugs, right, or reversible ischemia. Mobitz 2 is more likely a structural damage to the conduction system itself from infarction or fibrosis or chronic cardiomyopathy or something like that. These patients they often have pre-existing bundle branch blocks or bivesicular block, and the second degree AV block is produced by the failure of the remaining fascicle. Okay, so it is a progressive failure of the His-Purkinje conduction system, and impending things may be happening, like impending doom may be happening if you can't conduct through. Then things go wrong. So what's the whole problem with this? The ventricles, if you don't conduct through, now the ventricles are on their own. And sometimes the ventricles do fine on their own. Not for long. Sometimes they don't, right? Sometimes they freak out and they go into VTAC. So the ventricles can't be in charge of their destiny. That is the main thing to take home with complete heart block. They cannot be in charge of conduction. and the pacemaking. It must come from above. And if they suddenly become in charge, things can go badly rather quickly. A way to kind of remember why this is so bad is why Mobitz 2, how it's having normal PR intervals and then suddenly a drop off. It's like all or nothing. It can just suddenly stop. When there's signs of the conduction system suddenly just stopping, that's much more pathological than progressive AV nodal conduction lengthening, right? Which happens in Mobitz 1. Okay, so that's kind of how to think of it. So causes of Mobitz 2, they're pathological. You can have a new MI. As I talked about, you can have fibrosis, cardiac surgery, right? Especially occurring close to the septum, like a mitral valve repair. When you get close to that septum, then you can cause Mobitz 2, right? Inflammatory conditions, like I talked about, inflammation, any autoimmune diseases, anything that can infiltrate the conduction system, like a myocardial disease like amyloidosis or sarcoidosis. And then again, hyperkalemia and drugs, like I talked about before, can also cause this. All right, so this leads us to the third, the most serious of the heart blocks, which is the third degree heart block or complete heart block. And of course, and as you follow these things through, of course, this means complete blockage through the AV junction and nothing's getting through. So how is someone staying alive, during this? Well, there are intrinsic pacemaking cells throughout the heart. The SA node is the main pacemaker, right? But the atria itself has an intrinsic beat. The AV node, right? The junction be the atria and the ventricles, and then the ventricles themselves also have intrinsic rhythm. All of these intrinsic rhythms and pulses, or action potentials, I guess I should say, that can happen independently. They're suppressed by the SA node, right? So when everything's functioning, these other intrinsic pacemaking cells throughout the heart, they're suppressed under normal conditions. These pacemaker cells are suppressed by that more rapid impulse from the sinus rhythm. Well, now you take away the conduction in complete heart block, third degree heart block, and now these intrinsic pacemaking cells of the junction either take over. Usually these are lower heart rates, like 40 to 60 beats per minute, or the ventricles themselves have intrinsic pacemaking as well, but it's lower. Right, so the reason someone's even staying alive through complete heart block is one of two things. Either their junctional rhythm is taken over, so that the AV node junction, 40 to 60 beats per minute, that's maintaining their blood pressure, or it's just the ventricles themselves, which we call a ventricular escape rhythm, and that's low. That's like 20 to 40 beats per minute. So if you have a low ventricular rate, just the ventricles are keeping alive with their intrinsic pacemaker. This is dangerous, right? This can give out at any time, or you don't have a good enough pacemaking response to what someone's body's doing, and someone can die during it. You can go to cardiac arrest during third degree blocks. This is definitely an emergency. You must have an extrinsic pacemaker placed. You must. It's got to happen. So I'll share a story. So I've got lots of stories with this, right? I deal with this all the time. So while I was in my anesthesia role, right, I do anesthesia and critical care. So during my anesthesia role, I cover a day surgery center, right? Day surgery, right? So it's like not very complex surgeries, not very invasive surgeries. Generally pretty healthy patients. Although you can be sick, you can have a lot of comorbidities. But it's a lot of my responsibility then when I cover day surgery is I actually don't cover a lot of the anesthetics. I do pre-op evaluations. I see all the patients that are there to make sure they're safe for the operation, while the nurse anesthetists actually administer the anesthesia, and I'm just there as a backup for if anything goes wrong and to just make sure patients are safe for surgery. So I'm seeing lots of patients when I'm covering day surgery. I like it. It's a nice part of my practice. I wouldn't want to do it every day. My practice is very versatile. I do lots of different things, even in my anesthesia practice. But anyway, I had a patient come in for a cataract surgery, right? Cataract surgery is extremely benign thing. You could be on death's door and get your cataract replaced and you would survive that just fine. I'm exaggerating a little bit, but typically for cataract surgery, you don't have to have any anesthesia. Typically we give a little nurse sedation, meaning a nurse administers the sedation. And that what that means is midazolam and fentanyl, at least in my practice. That's usually what it is in other practices. Titrating to effect. Make the patient relaxed. The ophthalmologist numbs up the eye, does the cataract, 15 minutes, it's over, in an experienced center. And you don't even need to have any anesthesia at all. It's just most people find it unpleasant to have someone working on their eyeball while they're totally conscious. Anyway, it's a very benign intervention, and someone could be very, very sick, and this is going to be fine. Anyway, one of the nurses came up to me and said, "Hey, this patient's heart rate rhythm is weird. It looks low. I don't know if the patient's in heart block or what." So I went and saw the patient, and in pre-op before she got her cataract, and I looked at the heart rhythm, and I'm like, "Oh yeah, so." The hallmark, I forgot to mention, of third-degree complete heart block is you have complete dissociation of the P waves, and the QRS. They're just totally dissociated, right? In a normal EKG rhythm, you have P wave, you got the QRS, you got the T wave. And that repeats, right, in normal sinus. But now you just have complete dissociation. So what you do is you look at the P waves, and you're like, oh, they're just all over the place. This one's buried in the T wave, this one's buried in the QRS. And you have just total dissociation. That's complete heart block. It's a medical emergency, basically. It is. And how is the patient doing? The patient's doing fine, right? She was fine. She was like, "Hello, I'm feeling great." And I got an EKG, of course, to confirm because I was just looking at a rhythm strip. So I got an EKG and I saw it as well, and then I had cardiology review that, and they agreed. So in this case, the next thing I said to the patient, I said, "I'm sorry, we gotta," and she felt fine, right? Because her ventricle. I forget. She's probably in a junctional rhythm, keeping her alive. And her blood pressure was normal. She felt fine. I said, "Your case, I'm sorry that this is happening, but your case is canceled." I'm like, "I know you feel fine, but we have to cancel your case. And not only that, I have to put you in an ambulance and send you to the emergency department where you have to have this looked at urgently, I guess I should say, by a interventional cardiologist, and you probably need a pacemaker today." Of course, this is very shocking to the patient, but she was very understanding. And so she, I sent her on an ambulance, went to our emergency department, which is at a different campus where I work. That's why I sent her on an ambulance. Anyway, she had a permanent pacemaker placed about 2 hours later. Okay, that just to give you an idea of how serious of a situation this is when someone's in third-degree heart block. It must be addressed immediately. You cannot send that patient home. Right? If I had sent that patient home and be like, "Hey, follow up with the cardiologist," that would have been malpractice. In my opinion, you don't send a patient home in complete heart block. Nope, absolutely not. And and I'm glad she came in that day to get her cataract, right? Because she could have dropped dead at any time. Fortunately, that did not happen. All right, now let's move back to my cardiac. So I'm a cardiac ICU intensivist. So I work with post-cardiac surgical patients, right? Patients have very invasive surgeries on their heart, many different variety. I'm at a large academic center with many experienced cardiac surgeons who do a whole variety of cardiac surgeries, from heart transplants to minimal things like a mitral valve replacement or robotic mitral valve replacement, which is less invasive. You don't have to have a sternotomy for that. So a whole range. I work with many talented and experienced surgeons, and I take care of their oftentimes very complex patients that maybe a lot of other surgeons wouldn't even touch. So I'm a part of a very dynamic, exciting, fun practice with lots of colleagues, and I very much enjoy it. If you touch someone's heart, meaning if a surgeon touches someone's heart, they're at risk for heart block or conduction problems, right? So they always come up. Someone has a cardiotomy and a surgeon did something to their heart, whether that's a valve replacement or a CABG, a coronary artery bypass graft, or a septal myectomy for HOCM, or blah, 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 many things. They should almost always come with epicardial. So let me move this discussion to pacing, how to pace these patients. So I already mentioned a permanent pacemaker, right, with that other patient. Now these patients come up with epicardial pacemakers. What does that mean? Epicardial. It means it's on top of the cardium. So what happens is these surgeons place these little wires, onto the surface of the heart, and then they thread them through the skin, and then they're paced extrinsically through a pacemaker box. These are temporary. Okay, they are temporary. These are not meant to be permanent. Temporary epicardial, that's what they're called, temporary epicardial pacemaker. They always come up with them, typically. Why? Because they're at super high risk to going into temporary heart block, where we now need to extrinsically pace them. Patients who usually come off a cardiopulmonary bypass and cardiac surgery Now remember, we give these patients in the operating room, we give them cardioplegia, meaning plegia means paralysis, cardiac plegia. We stop their hearts. Why? Surgical exposure. So a surgeon can work on their hearts. So we stop their hearts and we put them on cardiopulmonary bypass, which is kind of like ECMO, but not totally, right? So the hearts are stopped, the chest is open, so the surgeons can work, and you have a bloodless field, relatively. What was my point? I forgot. Oh yeah, my point was that you put them on cardiopulmonary bypass, the heart gets cardioplegia, it's stunned, and so they're in asystole, right, during surgery. So they're not even conducting through their heart, right? And then you wake up their heart up at the end of surgery, and sometimes you have to shock their heart with these little kind of these cardiac pads specifically designed just to shock the actual surface of the heart, the exposed heart. Anyway, my point is patients, they have so many insults to the conduction system, these patients, that they easily can have various degrees of heart block, right? So they have epicardial leads. The majority of patients come up to my ICU with their native rhythm back. It's come back on board. It's intact. And so the epicardial wires are just there as a backup, a very necessary backup, because you can get ensuing inflammation over the subsequent days, infiltration of inflammatory tissue in that conduction system, and that can cause heart block. Or you can have scarring that later causes heart block, right? Or electrolyte disturbances, or AV nodal blockade agents that are very common in post-cardiac patients, like amiodarone and beta blockade, right? So there's many insults, there's many reasons someone can go in heart block. So you put epicardial, the surgeon places epicardial leads, you have that as a backup, okay? Now, as I said, patients usually return, they come up to the ICU. The majority already have their native rhythm intact, even within an hour of waking up from surgery, coming up from surgery, meaning their sinus rhythm, or they're back in their original AFib, their chronic AFib if they were in that, or whatever. Or it's also not infrequent. They come up and they're in complete heart block, and you're like, ooh, okay, this patient is in complete heart block. Okay, I'm gonna make a mental note of that, because those epicardial wires are literally the only thing that's keeping the patient alive and keeping their heart beating. And so I always check. If someone's in heart block, I want to know what are the. And you know what? Now I need to do an episode about pacemakers, pacemaking boxes. That's what I need to do an episode about that. Remind me if I haven't done that in a bit. Email me and tell me to do that. Anyway, so I check what are the now. Usually they have atrial wires and ventricular wires, AV wires. And the next thing I want to know, hey, they're in complete heart block. The next thing I want to know, what are the thresholds? That they're how many milliamps do I have to give them through the pacemaker, extrinsic pacemaking box, to capture rhythm and keep them alive? Is it a lot or is it a little? Very important to know, right? Because if my output energy, my milliamp is high, and I would consider high, 20 to 25 is very high, and if it's high, that means I'm having to deliver a lot of milliamps to capture. And that's a dangerous territory. You don't want to be high because there's only because you craps out after that and you no longer can capture, and then you can go to heart block, the patient go to cardiac arrest. Typically, when someone's fresh from surgery, that you only have to give them like 2 milliamps or 3 to get capture, and you have plenty of buffer room because they typically go up to 20 or 25. So you typically have lots of buffer room. What happens to epicardial leads is that the resistance goes up day after day. They can migrate away from the epicardium. They migrate away, and then the actual leads, the material, the resistance can go up. So you will see day after day, the resistance can start, the milliamperes that you need to give, the delivery, the output energy goes up and up and up and up. Okay, and an unacceptable state is when you have just epicardial leads and you're in complete heart block and you're delivering 20 milliamps to just get to capture. That's not acceptable. That's way too dangerous. You must escalate your pacing to make, because that's just way too dangerous of a tightrope to walk. If you're following me. If you're not, don't worry about what I'm talking about. So what do I do? So what do you do? Well, your options are, you can put in transvenous pacing wires. Some institutions have a pacing swan or PA catheter, or some just basic wires that you float with a balloon, and you can just do ventricular pacing. Now, in a pinch, I'll do that, right? And you have to put an introducer catheter into typically the right internal jugular, and you float trans-pacing wires. Now, I will do that in a pinch. If I'm like, I got to get something in right now, I have to have some backup pacing, I will do that, or a pacing swan. I find pacing swans to be a little maybe not as reliable. Now you can do that in a pinch. Okay. Let me back it up. Someone can go in a complete heart block 9 or 10 days after the cardiac surgery, and at that time, sometimes their epicardial leads have been cut or pulled. Now you don't have any backup pacing. So I've not infrequently it happens. I suddenly am called to our step-down unit, our cardiac step-down unit, meaning patients not in the ICU. They're doing great. I come, it's a code blue. Someone's on the chest doing chest compressions, and you get ROSC. They wake up, and I look at the pacing, the rhythm, and they're in complete heart block. They go back in asystole. You have to keep pace. And this is heart block. I know it. I know they're now in heart block. And my next word on my mouth is, do they have the epicardial leads? And of course, by some sort of twisted poetic justice, their leads were pulled an hour prior or something like that. Now, once I make sure I've ruled out tamponade, because a lot of times patients have now started warfarin as well, and then their epicardial leads are pulled, and now they can be bleeding around the heart, and they can have tamponade. I've also seen that. So you got to make sure they don't have tamponade by putting in a ultrasound probe on their chest. Well, after I've quickly ruled out tamponade, I know this is heart block. You got to immediately try to transcutaneous pace. That's the first thing you do. Transcutaneous pace, put on pacing pads, and try to get capture. That is notoriously bad at getting capture. But it's the first thing you got to try. Okay, you put that in, and then you hope that they still have an introducer central venous line in their IJ, and then try to float down. Get them into an ICU if you can, because where you have more resources and staff that are more comfortable with this type of thing. It's always a very dramatic bounce back, right? This is the most dramatic bounce back to the ICU is someone that's gone into complete heart block, because you're typically thumping on their chest, doing chest compressions to keeping them alive as you roll in. Now, so transcutaneous pace, try to do that. The capture is often bad. Sometimes just give them little bumps of epinephrine. That can keep their ventricles going. That's fine. 10 mics, 20 mics. Give them some couple bumps of epinephrine. Try to keep their I've kept people alive just with bumps of epinephrine when they're complete heart block. I have, while you're then trying to float pacing wires. Try to get capture. Sometimes you can. Sometimes it's good. Sometimes you're just in this. You're in this spot where it's not perfect, but they're alive. And then what are you doing? It doesn't matter what time of day. You are calling the procedural cardiologist. Sometimes called EP, electrophysiologist, or a heart rhythm service, whatever. They may have different names, but it is a interventional cardiologist. And you say, you typically, now you got to use very direct language, particularly if it's like 2 a.m. You say, I have a patient who is in complete heart block. I have unreliable pacing. This patient needs at least a temporary permanent pacemaker right now. Will you please come in and do that for me? And then, they're like, what? You got to answer the questions, but, orient them quickly to the situation as fast as you can. And, prep tell them to prep your OR and have them come in, because it has to happen. And then you can have a discussion, well, maybe we should just put a permanent pacemaker. That's fine. I don't care. That's their call. Now, a temporary permanent pacemaker sounds like an oxymoron, right? A temporary permanent pacemaker is where interventional cardiologist or EP cardiologist, whatever, floats pacing wires down to the ventricle from the IJ and nails it screws it into the myocardium, so it's not coming out. That's what makes it permanent. This is intraventricular, but then the pacing box is outside of the patient's body, usually taped outside the patient's IJ on their neck. That's what makes it temporary permanent, because it can then be removed and taken out, and you don't have the actual pacing box placed under the skin, which is what a permanent pacemaker is. And permanent pacemakers are usually transvenous as well. Now that's a discussion that the surgeon and the cardiologist can have if they want it to be permanent or temporary permanent, that case by case basis, whatever. But a temporary permanent is durable pacing. I've never seen a temporary permanent pacemaker not function. That's not possible. So once they have it in, they're good to go. They can leave the ICU. Then as soon as they have that, they're fine. They now have durable pacing, and they're now stable. And I've brought patients to the ICU like this, and I'm literally, we're doing chest compressions, keeping them alive, and then the next day they leave the ICU and they're fine. They turn out fine. These patients are fine. Now you have to talk them through it, because a lot of times they're awake for these chest compressions because they're getting some perfusion and they can be awake. I try to give them a little midazolam as I'm shocking them, and I apologize and say, hey, this is necessary. We are doing this to keep you alive. I talk them through it. And when I talk them to the next day, when this happens to my patients, they're very understanding. of the situation and what happened and why all of those measures were necessary. They really are. Anyway, this is a big topic. There's a lot more to talk about. I should do an entire episode about external pacemaker epicardial troubleshooting and how to do that, because it's a big part of my practice, and it's very important to be proficient with it as well. Anyway, I'll wrap up the discussion. I hope it was helpful and you enjoyed it. All right, on to our book portion of the episode. All right, I'm talking about 2 books. The first book is called Nuclear War, A Scenario by Annie Jacobson. This book was published this year, 2024, March 28th. It's 400 pages long. I listened to the audiobook for this one. So, this book, Nuclear War, is the worst book I have ever read. And I mean that as a compliment to the author, because it means she did her job with this material. So this book, which is about nuclear war, it was not entertaining. It was not fetishizing some sort of post-apocalyptic fantasy, escapism, and it did nothing, utterly nothing, to bolster the utility, in my opinion, of nuclear deterrence. This book had one job, and it did it well. And this book's job was to emphasize the utter disaster of nuclear proliferation and the ever-present threat of near-total human extinction that we face literally any day. Since the inception of nuclear warfare, humanity has always been at risk of annihilation. It could happen next week, tomorrow, or while I'm finishing this sentence. And that's what this book is about. A possible scenario in which most of the world is engulfed in a conflagration of nuclear fire and fallout. Now, the author goes over a specific scenario that the whole book, she teaches you, and she offers a scenario and works with it through the whole book while she teaches you about the major players, the U.S., Russia, and North Korea in this scenario. Granted that Israel, France, UK, India, and Pakistan also have nuclear weapons, and probably Iran does too, let's be honest. It's the other 3 that would probably start is, Russia, the U.S., Russia, and North Korea. Oh, I forgot to mention China. It's these 4 right now that would probably start a nuclear war. The scenario here is North Korea, in the book, attacks the U.S. out of nowhere with intercontinental ballistic missiles, ICBMs, warheads, alongside a nuclear attack from one of its old submarines that has sneaked down the Alaskan coast and down to California, which it could do undetected. The 2 strikes here are that in the scenario that North Korea does in the U.S. are decapitation strike at the Pentagon, right, striking the Pentagon with an ICBM, and the other is a nuclear facility in California. That's the scenario here. The ICBMs would be detected by the U.S. as soon as they're launched by our satellites. After this detection, the U.S. president would have about 6 minutes to decide what retaliatory action would be taken. 6 minutes, which is a ludicrous amount of time. It takes me more than 6 minutes to brush my daughter's teeth at night, to go through that. The U.S. cannot stop an ICBM nuclear warhead. Apparently, there are like 40 anti-ICBMs along the Pacific coast, but they work only like half the time, and both North Korea and Russia easily have enough ICBM nuclear warheads to overwhelm that defense. Let me repeat that. There is no U.S. defense against an impending nuclear attack. Okay? If a country decides to, if Russia or North Korea want to drop a bomb, they will, and it will explode over a target of their choosing. That's a fact. There's nothing the U.S. can do to stop that once they detect it. In this scenario, the U.S. knows the ICBMs are coming from North Korea, and the retaliatory U.S. strike takes the form of a trident of the U.S. ICBM from nuclear bases here in the United States, Ohio-class submarine nuclear strikes that are just out there, or warheads from a plane. Okay? That's a trident. That's a nuclear trident. These strikes can come from the U.S. or from a UN bases in Europe. In the scenario in this book, the U.S. retaliates with a bunch of ICBM aimed at North Korea. D.C. and its surrounding areas are destroyed by the first nuclear strike. The president is dead or lost, and Russia now believes the U.S. is attacking as it detects those ICBMs incoming, and so it releases an ICBM strike against the US and the UN bases in Europe. Whoever is still in charge in the US would then strike Russia. And that's it. That's the ballgame. Not only would the initial blast kill hundreds of millions of people, but the nuclear fallout and winter would in total kill billions of people worldwide and usher in the end of modern civilization and possibly extinction. This is not fiction. It could happen tomorrow. All it would take is one misunderstanding and we are all dead. Deterrence works until it doesn't, and then the world is on fire and we're all dead. It is utter lunacy and madness that this is the underpinnings of our current global world order. I don't know what to do about it. The author doesn't really either, but she's very knowledgeable and she lays out this scenario with chilling detail. And honestly, no hyperbole is enough to describe the threat of nuclear war. No hyperbole is enough. I don't know if you're in a mental space to read this book, but you should. But I don't know what to do with this information. I as a just a normal citizen, I can do nothing productive with this information other than just worry. So maybe don't read this book. Anyway, it's called Nuclear War by Annie Jacobson. All right, next book is called Strongmen, Mussolini to the Present. This book is by Ruth Ben-Ghiat, which I'm sure I mispronounced. The last name is spelled Ben-Ghiat. First name is Ruth. This book was published in 2020. It is 384 pages. So this is Strongmen. It's not a bad book from a historical account of several strongmen or authoritarian rulers from Mussolini to the present. With this book, you'll get scattered tidbits of history and the common strategic ploys that these strongmen have made that bind together a narrative that the author is putting forth here in this book. There's nothing super revelatory or earth-shattering about this book, and I've honestly read many books like it, but I did enjoy the historical accounts. However, this book has an enormous misstep by only talking about right-wing authoritarian rulers without sparing a sentence for left-wing authoritarian rulers. That should have been a large part in this book about strongmen, which I'll get into in a moment. Sorry. So this book covers Mussolini, Hitler, Franco, Pinochet, Gaddafi, Putin, Mobutu, Berlusconi in Italy, and Trump. The historical accounts of these men, how they came into power, and what they did with it is what this book excels at. The fascist strongmen have several features that all these men kind of share, okay? And in no particular order. Destruction of media, ownership of media, spreading falsehoods, propagandizing conspiracies, misogyny, sexual exploitation, courting paramilitary groups, subverting traditional liberal democratic precedences, anti-communist panic, fostering a cult of personality, and harsh domestic civil rights violations, amongst other things. All of these men I mentioned foot the bill. Even Trump does. However, Trump is different than the other strongmen mentioned, and I feel this lack of nuance discredited the author a little bit. Trump clearly uses fascist rhetoric and tactics and has wielded them with skill to gain control and to be elected for a second time, right? At this current moment, he's the president-elect. However, Trump has not committed anything close to genocide, murder, and civil rights violations that the other men in this book have committed. Does that make Trump a sweetheart that doesn't deserve the fascist label? No, of course not. In my opinion, Trump is clearly a fascist, or at least a fascist-adjacent politician, and the most generous interpretation. But every time the author made a side-by-side comparison with Mussolini, who was awful for many reasons. He invaded Ethiopia, murdered their civilians. He sided with Franco and Hitler, after committing rape in his own private quarters. So, how the author talked about these people, Mussolini and then Trump, really made my eyes roll. Trump is simply not on the same level as the other men. He's not. He simply is not. Now, he could be, right? But he hasn't approached that yet. But by making these premature comparisons, I believe it saps the strength of the argument that Trump is a fascist. And all the pretty clear warning signs of Trumpism just kind of fall on deaf ears. Trump is a rising fascist, and he can get much, much worse than he did in his first term, certainly. Now that people start just calling him Hitler, like his own vice president, which is weird. Half the population just kind of ignores the warning, right? They just kind of gaslight. And I was like, they're just like, oh, you silly liberals, right? It is extremely important to be accurate and precise with language. And I feel this author was too reckless, and this book only served as a confirmation bias to readers who already agree with her. Now I'm going to get to the glaring omission of this book. Okay. 3 people, Stalin, Mao, and Xi Jinping. Xi. Where were these guys when this book was written? These 3 men fit the time period the author covers and also fit every single metric the author puts forth to be a strongman, except for one, anti-communist panic. I argue that literally the only thing that separates a fascist from Stalin and Mao and Xi is using anti-communist panic to create and harness a reactionary political landscape. That's it. Otherwise, communist dictators are also deplorable strongmen and make great bedfellows with the likes of Hitler and Mussolini and Pinochet and Franco and Gaddafi and Mobutu. So the underpinnings of this entire book are ideological, meaning the author has ideological blinders on, and it weakens all of her arguments. Autocracy and authoritarianism come from both sides of the political spectrum. In our modern time of rising fascism and the danger of reactionary politics, it is extremely important to remove our ideological blinders lest we fall for a strongman on the other side of the spectrum, right? And that was a major misstep with this book. I still like this book, but it had problems. Now I'm going to give a little more about this book. So I published what I just told you. I wrote that was a review I wrote on Goodreads, and I have a friend. He's a social media friend. I don't know him in real life, but we have a lot of discourse over the years. And I'm going to read you his comments about what I just told you, the review, okay? And then I'm going to read you my comments back, if you care. I think it's interesting, okay? So TJ, he says, nice review, interesting. I know the left is fully convinced that Trump is a fascist, and I agree he has selectively flouted some conventions and made some worrisome statements. But I agree with you. I think his actions in creating a fascist tomorrow are basically nothing. A lot has been made of Trump's statements. For example, he said immigrants were poisoning the blood of our nation. Another time, he referred to some of his opponents as rats. Leftists were quick to point out the similarities with these phrasings and things Hitler and Mussolini said. To me, this argument is contradictory. Either you believe Trump is a secret fascist reading all of their books, slipping in their quotes to signal his fascist followers, or you believe that Trump doesn't read, but he is a populist. He talks a lot, he engages in invective, and so it's not surprising that eventually some of his comments might be similar to some of the comments of fascist populists of the past. I'm in the second camp, says TJ. We all know Trump doesn't read his security briefings. He can't be both people. I don't think he reads Hitler or Mussolini. I think he called some people rats just for variety because he's called his opponents everything else. Okay, so that's my social media friend. Those are his comments. Here was my response to him. I said, thanks for your comments. Always appreciative. Whether we call Trump a fascist or not is a matter of perspective. Trying to be as objective as possible, Trump's actions parallel those of fascists. He courts paramilitary groups, he has attempted to produce votes to win an election. He denied the lawful result of an election. He denied the lawful transfer power to his successor, as well as encouraged his followers and vice president to stop the certification of his successor, which resulted in violence and some deaths. Trump certainly uses fascist rhetoric and tactics like evoking divine nationalism, ethnic resentment, immigrant scapegoating, leftist panic, as well as courting other modern authoritarian leaders and stating that he himself will act as a dictator. Trump has harnessed the perceived cultural and economic loss of a rainbow coalition of the outraged and discontent and has leveraged their grievances into political power. I call that fascism because it's very similar to fascist movements of the 20th century. You can call it whatever you want, but I will say that one doesn't need to read about fascists or even be aware of the phenomenon of fascism to be a fascist. That's a strange qualification to make. Either way, Trumpism is deeply troubling to me and parallels many of the strongmen mentioned in the book. That's the end of my comments to my friend TJ. I just thought you might find that exchange interesting. And there you have it. So the book was called Strongmen, Mussolini to the Present, by Ruth Ben-Ghiat. Anyway, that's it for me. Thanks for listening. Email me at icudrecmo@gmail.com, ICUECMO, ECMO, @gmail.com if you would like me to discuss a topic on the show. If you have any comments that you would like me to know. I take licensed to read your email on the podcast anonymously unless you tell me otherwise. So let me know if you do not want me to read any of your comments anonymously on the podcast. Otherwise, I will take the liberty to read portions of your email or your entire email if I think it's a good topic. Please rate and review this podcast on Apple or iPod. What's it called? iTunes. What is the Apple? Whatever. The iPod, podcasts, whatever, on Apple or Spotify or wherever else you listen to this. Please rate and leave a review. Thanks for listening, and I will see you next time.